Hello, everyone, and thank you for joining us on this episode of the Eckhart and Koka Report. Returning to the show is Mark Tonelli. Dr. Tonelli is professor of medicine and section head of the Division of Pulmonary and Critical Care Medicine at the University of Washington Medical Center in Seattle, where he is also fellowship director. He holds a BA in philosophy from the University of Colorado and an MD from the University of Colorado in Denver, and an MA in medical ethics from the University of Washington. He's the author of many peer-reviewed articles and book chapters. Last time we had him on the show, it was to discuss medical epistemology and his thoughtful critique of the evidence-based medicine movement. But today we'll be talking about what is on everybody's mind, which is the COVID-19 pandemic. Mark, welcome to the show.
Thanks very much. And I should just say that I gave up the pulmonary and critical care fellowship director job when last year. And at the moment, I'm glad I did because I have enough other things to worry about right now.
Sure. But I think you're still obviously, or well, you'll tell us, but you're involved in critical care medicine and being an attending.
All the other positions are still the same. Yes.
Okay.
I'm still the section head here at the University of Washington Medical Center for pulmonary and critical care.
So, Mark, the state of Washington and I think Seattle and the university were the first hotspot in the United States with this pandemic. And
correct. That King County in particular, the county
Right.
that Seattle sits in, saw the first cluster. We actually, Snohomish County, just north of us, had the first case in the U.S. way back in January, I think, or February, and then we didn't hear much about it until the outbreak in Kirkland, which is just the other side of Lake Washington, in late February. Yes, one of the certainly the earliest clusters and some of the first deaths in the U.S.
So can you think back and even remember when, did you think that was something that you really had to give up to and deal with?
So it's interesting because when we had the first case in Snohomish County, I was wondering, I was on the ICU then, and I was sort of on the lookout the next couple of weeks and thought we might start seeing some more cases, and we really didn't. And I think, like much of the country, people got a little complacent. It seemed like that initial case had not spread to anyone else. And it really wasn't until the late February when the cases started coming out of the Life Care Center in Kirkland that it was clear that the virus had been circulating here for quite some time. Similarly, at about the same time, there was a case that was diagnosed in a high school student in Snohomish County, which was based purely on serendipity. The sample that person had given wasn't being sent for COVID. Nobody was doing that kind of testing. It was part of a flu study and became positive in that realm. And so suddenly we realized that the virus was here. It was circulating throughout the region, and it rapidly started causing fatalities.
How come the first case was even tested? Was it?
The first case was a traveler coming back from China and had symptoms, and so that was the first U.S. case.
And that was the sample was sent to the CDC, presumably.
At that point, yes.
Right. Okay. And so when did things begin to build up, if you recall?
So in late February, really, it turned out that most of the cases that were being seen at Life Care Center in Kirkland were going to a community hospital there called Evergreen Hospital. They were the ones who actually first figured this out. They got suspicious. They were getting multiple patients from the nursing home, and they started seeing ARDS without another cause, and they were the ones who called the CDC and arranged for the testing, and suddenly they realized they didn't just have one or two cases, they had an entire cluster. The CDC came along with King County Public Health and went into Life Center and found that a large percentage of those patients were actually infected. It turned out that there had been a death at one of our institutions, Harborview Medical Center, earlier in the week, an unexplained ARDS that also turned out to be due to this. So suddenly we had not just a few cases, but a large cluster in a very sick and vulnerable population. So the death count went up rapidly after that. For the initial, I would say for the initial first couple of weeks, Evergreen Medical Center did a tremendous job of surging up, handling these patients, and they largely handled many of these cases on their own. Some of the other cases from the Life Center were then, through our disaster management committee, sent out to other institutions in the region to help offload Evergreen. But they did a tremendous job early on and really bought the rest of us, I think, some time to start planning for this and implementing our contingency plan.
Mm-hmm. And by then, late February, clearly China was already, was at its peak, or, clearly, I mean, you could see the right.
Yes,
And,
we knew obviously early on what lay ahead, that there were that this had been circulating for 6 weeks, that there were hundreds, if not thousands, of cases in the region, that they were all over, and that a certain percentage of those folks would be getting seriously ill. Probably somewhere between 15 and 20% of them would get seriously ill, and 3 to 5% of them were going to end up in our ICUs. So yes, we knew right away what we were facing.
So what happened next? I imagine immediate meetings with the CDC, the local health departments. I mean, some plans to deal with this.
So the CDC and came in to try to help with the particular outbreak, and Life and the King County Public Health initially was trying to do classic case tracing for each individual case as they started to come up, but they were quickly overwhelmed, and it became clear that we were not going to be able to manage this like an outbreak, per se, and try to contain it. The containment wasn't going to work, and that we were going to need to move to mitigation very quickly. And then each institution and healthcare system in the region started ramping up. We all have had contingency plans for these types of things. So it was starting to put some of those contingency plans in place as the number of patients started to increase. The initial hit is obviously on the emergency medicine departments, seeing these patients, trying to keep their folks safe, trying to get the testing done. We were lucky that the University of Washington was approved very quickly by the FDA to do their own testing, and so the state lab was relatively slow and cumbersome. And so once we had testing within the University of Washington, then most of the other institutions in the region sent their tests here. And we could get a much more rapid turnaround.
Mm-hmm.
And that proved to be very helpful early on.
Right. What about equipment, especially protective equipment and that sort of thing?
So as you're probably aware, most institutions run relatively lean, and the amount of personal protective equipment on hand is relatively low. And suddenly the burn rate goes way up because now we have to treat everybody who comes into the emergency room and into the inpatient services as potentially COVID positive, particularly if they have any symptoms whatsoever. So suddenly we were using a lot more. Everybody is short. We have changed our protocols based on some CDC guidance and our own infection control, trying to conserve our PPE. But basically every institution here is relatively short on PPE. And if there was any advantage of being first, we could get the first request into to the federal government for to try to release from the national stockpile. We got, I think, some PPE via that mechanism, but for the most part, we're kind of on our own now.
Okay, but it never got to the point where you were essentially having to send doctors or nurses without what you thought at the time, perhaps.
We do not. Yeah, we do not want to do that. And again, I'd say Evergreen Hospital was very well prepared for this and well resourced, but early on, the having to reuse or to have single use a single user N95 and to use your N95, for multiple patient visits, cleaning, PAPRs appropriately. So there are those contingency plans for PPE, but they're not, never were we putting healthcare providers in harm's way. And I think from it as an ethical, point, that's not something we can ask of our healthcare providers. I mean, it doesn't make sense either. If they get sick, even if they just get a mild illness, they're out for 2+ weeks. And so, that's a resource we really can't replace. We can try to get more PPE, but we can't replace our healthcare providers. And so they need to be protected. That's changed how we deliver care. It's batched. We don't go into patient rooms. This is a teaching hospital. Very early on, it stopped being, the usual 10, 12 people going into, a team going into a patient's room. If PPE were required, that's just not a good use of your resource.
Right. What about bed capacity?
So in terms of bed capacity, we are currently doing all right, as is the region. Relatively early on, we stopped doing non-emergent surgical procedures. A lot of our outpatient medicine went to telehealth. We made a concerted effort to get patients who were inpatients out to skilled nursing facilities, which is a little bit of a challenge, in particular if they were COVID patients. Trying to get a nursing facility to take them back has been a challenge, but non-COVID patients, get them out to try to clear the decks so that we actually have space. At our institution and at other institutions, the need for negative pressure rooms was acute. Many of the institutions in this region have a relatively limited number of negative pressure rooms. So the engineers at multiple institutions have been very, very busy. We turned our entire surgical ICU into all negative pressure rooms with the option to turn the entire unit into a negative pressure unit. They did similar things at Evergreen to 2 of their actual ICUs. And so those things were all in, all part of the contingency plans, and they were implemented. We currently are, as a region, all right on ICU beds. We have not exhausted our ICU bed capacity, but we don't expect to reach our peak for another 2 to 3 weeks. So we know that's coming. And so there's been concerted effort to not only take inventory of ventilators, to get other ventilators that would be available to us. We're talking about being able to utilize our anesthesiology machines for ventilators, and then the space in the hospital. We have a tiered response at this institution in terms of the space in the hospital that we're going to take over to convert to ICU beds as this moves on.
So
why do you think you have to, why do you think the peak is in 2 weeks?
That's what all the models say. So this is this is an interesting disease in the sense that the time from infection to symptoms usually is probably somewhere around 5 to 7 days. The time from symptoms to the worst part of the disease tends to be about 8 to 10 to 12 days. I think just, to me, it's interesting in the sense that this is a classic Hippocratic disease in terms of it has a crisis. You get the illness. You have the illness, and then for most people, somewhere out in 8 to 12 days, they will either, get better, they will reach crisis, they will either get better or they will get worse. And so with all of that, and if they get worse, they end up on the ventilator. And if they end up on the ventilator, if they get worse, they end up in the hospital. If they get really bad, they end up on the ventilator. And if they end up on the ventilator, they're staying on the ventilator for 2 weeks, whether they live or die. On average, so we're really looking at a disease that, even if we have stopped people infecting other people today, we're not going to see the peak of it for 3 weeks or so, particularly on the ICU side.
But the first peak that you had, so you think it was sort of because of that cluster, because of that nursing home, you saw a little peak, and then it wasn't really that much spread in the community at that point. And now in a couple of weeks, you will see the actual peak from the community spread, essentially the natural history of this. Okay.
Yeah, from the models that we have, I mean, I think Yeah, in some ways it might have been fortuitous for us to have actually had this initial cluster because it got everybody's attention very quickly.
Right.
Because this disease, you could see, could be percolating through a community for even longer than it was here before somebody figured that out, because we weren't doing any testing.
Right.
And it really required like the sharp, the astute, clinicians at Evergreen to recognize that this wasn't right. Something was different, and they had this, and having that cluster, I think, motivated that. One case of ARDS that's unexplained is something we see not infrequently in the ICU. But when suddenly you're seeing 3, 4, 5, and they're all coming from the same place, I mean, you can't isolate an infectious organism, then that gets people's attention. So that might have helped us. But then again, like right after we recognized that, it wasn't that everything stopped in Seattle. The social distancing measures were put in place over a period of time. First with relatively soft recommendations, then with banning big groups, then with eventually closing schools and closing universities. The universities closed before the public schools, to the point of closing restaurants, bars, and now pretty much all businesses, non-essential businesses. But that all occurred over time, right? It didn't happen once we had this first cluster. Arguably, if it happened when we had the first cluster, we would be seeing our peak around now or next week. But
right. So the you expect, I mean, based on those models, you expect to be at, I mean, you're reasonably comfortable now that, again, you've had that warning, you have capacity, there's maybe some federal help for more equipment or that sort of thing. The whole country is gearing up. How do you view things coming up, over the next few weeks?
So I think we're going to get very busy. It's not clear how high our peak is. We're already very busy, but we're going to get busier. So we know that. So we know that we're going to, our daily census of COVID patients is going up consistently, and it's going up consistently across the region. And we know that that's going to continue. We're hoping that will not be exponential growth, that will overwhelm the system, but we're developing contingencies for those situations, but in terms of expanding our ICU bed capacity, which is really the limited resource for this disease, but also expanding our acute care bed capacity. There are tents going up there to allow for some additional bed capacity for patients who are either recovering from their illness or early in their illness and not yet in need of much more support than some oxygen therapy. So we're increasing our overall bed capacity, our ICU bed capacity, and we're preparing for this to get much worse before it starts to get better.
Okay. Are you ready to talk about making decisions under uncertainty with?
I'd love to talk about
in
that.
a situation like this. What comes through your mind? First of all, I mean, I don't know how much experience you had with SARS, even theoretical experience, or SARS virus, or the previous pandemics that were sort of like, I mean, different, but the warning signs of
yes,
and how much you could draw on that knowledge versus this one. And then you see reports from China. I suppose you try to learn what they've done there, China, South Korea, and so forth. And
Michelle, before he asks that, can I ask him a question about about this this expected? So you guys, I just checked. You guys are at, and these are, I'm sure, accurate because you guys are doing such a great job at the University of Washington in terms of tests and stuff. But you guys right now are at 236 new cases a day, 315 new cases a day. And you're saying, based on that, 300 new cases a day, you're expecting, to get significantly busier in the next couple of weeks. Is that accurate?
Absolutely. Yeah.
Wow.
Of
course, yeah.
I mean,
because of course, New York City has, we're talking about 6,000, 7,000 new cases a day.
Oh, absolutely. I think I would say we are in a better position by far right now than New York City. I think And we could talk about why that might be the possibility, but they are looking at exponential growth. Their numbers, they're doing much more testing. Their numbers are higher, but I think they're seeing a very high number of high acuity patients. Yeah.
Do you think your community spread is, if you had to guess compared to New York City, how much is your community spread?
Well, I think, originally the community spread is probably roughly the same. I mean, there are those of us who think there's something called the Seattle chill, which is this, attitude that Seattleites are supposed to have that's kind of distant and off-putting. So perhaps our level of social distancing is at baseline higher than other places, and maybe that's an advantage. I think that our population is not as dense. But the R naught for the virus is probably pretty similar. So we don't have as many people as New York. So our case numbers are not going to be as high. And I do think based on all the modeling, it looks like our curve, this notion of flattening the curve, that our curve is flatter. And based on what we're seeing in the we're 4 weeks into this, and what we're seeing in the first 4 weeks of this is that we are, flatter. Arguably, other places like New Orleans and New York, where their initial clusters followed ours, are on a much steeper part of that curve, and so
have you been
much more.
Do you know if the last week or two has shown more hospitalizations per day or more ICU for you folks? Yes. Are you seeing just?
Oh yeah, absolutely. Yeah, though they continue to climb. And we're keeping track. I'm keeping informal track of what's going on with the ICUs in 14 institutions around the Central Puget Sound region, and I'm in contact with physicians in those places. And yeah, our overall census, both ICU census, COVID census, number of COVID patients on the ventilators is going up in every institution, and we know it's going to continue to go up. And the other reason it's going to continue to go up is not just that there are new cases rolling in, but as I said, these patients don't come off the ventilator quickly, if they come off at all. The mortality for this disease is, extremely high, even in patients who end up on mechanical ventilation. It's hard to say what it's going to be in the U.S. It was, in most Chinese reports, in excess of 90%.
What is it in your experience?
Well, it's too early to say, because we have, we're right in the middle of it. And like I said, these patients come off, it takes 2+ weeks for many of them to come off the ventilator. So we have a lot of patients still on the ventilator who may survive. I'd say in the early days of, looking at the Evergreen, which has published some of their data, and then the University of Washington system, which is trying to publish some of their data, it looks like, clearly there's going to be a mortality of over 50% for patients who end up on the ventilator. How much higher than that is hard to say.
Can I ask you what patients ultimately are dying of?
So there are patients who come in very acutely ill, and we saw this in the first cluster. The Evergreen folks reported this. They were really, really good. They were so busy, but they were really good about reporting to the rest of us what they were seeing. And they saw a lot of patients who came in really just very acutely ill, developed cardiomyopathy, and circulatory collapse, multi-organ failure, and died relatively rapidly. Otherwise, what we're seeing in the late folks is, that's what kills patients in the ICU who are on protracted mechanical ventilation is basically multi-organ failure. Right. And so developing multi-organ failure in that period of time before they get any recovery of lung function. So that's what we're seeing, early on.
Okay.
So your testing capability seems to have been really key to get you prepared, adequately, and must be helping now. I've heard some reports that you have plenty of testing capacity. It's not. I mean, you're right. That wasn't a bottleneck for you guys.
It was initially. So when this first came out, we only had the state lab, and they were only running 200 tests a day. It was once the UW Medicine got online. That the testing capacity ramped up relatively rapidly. Okay. And currently, I would say, testing capacity is not our limitation at this point in time. Although we also are still limiting our testing. We're not doing community-wide testing here. So if you're sick in the community, you cannot, really get a test.
Mark, why is if the would you say you're over the hump in terms of the flattening of the I mean,
No,
there's some thought that you're not.
no, we're not. No, like I said, the peak is yet to come. We're not over. We're not there, but we're far past where you could do contact tracing. It's all about mitigation at this point. There's widespread community spread, and so we're testing vulnerable populations, nursing homes, assisted living facilities. We're testing hospitalized patients. We're testing healthcare workers. So we're prioritizing those tests as well. And then you may have heard it's starting to get to be a problem now that we can do the testing. Places are starting to run out of the swabs to actually do the testing. So that's another challenge in terms of coming up with those. So
all the patients you're seeing, you're well beyond the initial nursing home.
Oh, we're well beyond the initial nursing home. Yeah, that facility was almost essentially emptied out over a period of several weeks. But we're seeing outbreaks in other skilled nursing facilities, and then we have just community outbreaks. Most of the folks that we're seeing now, there's not a clear risk factor for their disease.
Do you have a sense of the performance of the test in the community when patients are not that sick? We talk about the sensitivity of the test, whether it's good enough and so forth. And our patients our patients who are not very sick, do they get tested serially if they get sicker?
Yeah, so that's it is hard to say anything about the performance of the test because it's sort of the gold standard. But we have seen some cases where somebody will be negative and then eventually be positive. Is that because they were positive all along, or were they actually negative and converted? So it's hard to say. But I think the test performance is very good.
Okay.
You do have to sample, right? There is this push now for home sampling, and there's some early data that suggests you can have people do their own samples, and that it's relatively good, but clearly it's not going to have the same sensitivity that a properly done nasopharyngeal swab does.
Okay. Anish, anything else that you wanted to ask? Okay. So so you're confronted with this new virus, new pathogen. You know a little bit about it from what you hear from China, and so forth. What goes through your mind, either in terms of what you need to prepare for, or what you can do to address, or you see this thing that could overwhelm your system? I mean, I suppose that 2-3 weeks ago, there was a real possibility, right? That
it remains a possibility.
Right.
I mean, given that the peak is not here yet. Yes.
Right. How do you? I mean, what did you do differently, if anything, that apart from what you've mentioned already?
In terms of managing these patients. So I do think one of the things that's very interesting, so one of the recommendations that came out of China, and it makes good sense, and we're doing that, is trying to cohort these patients. So like I said, we took our entire surgical ICU, we converted it to a COVID unit, we made negative pressure rooms. Other institutions are doing the same thing. And then we have a team that's managing these patients. So it is very interesting. I was on this over the last several days, and to have an ICU where all of your patients have exactly the same problem is strange. And they all have a problem that is in some ways familiar, but also quite new. So there are things about this illness that, there's a lot to learn. It does cause ARDS. So patients go on the ventilator, and we manage them as if they have, as we would any patient with ARDS. And yet there are some features of this disease that are different than ARDS. For instance, the lung compliance in these patients tends to be pretty good. Their lungs aren't particularly stiff, which is raising the question of, do we need to use such low tidal volumes as we usually do in ARDS? Because one of the problems with that is that if we use low tidal volumes, we usually have to sedate patients and sometimes neuromuscularly block them in order to do that, because patients don't really like the low tidal volumes. And maybe we're having patients stay on the ventilator longer because they're getting oversedated and or neuromuscularly blocked. So that's one of these questions of, looking at the physiology of this disease. Do we need to start thinking about, changing our usual ARDS strategy in this patient population? It's also unclear if there's anything besides supportive care that helps with this disease, right? So, and we know the outcomes are pretty poor even with supportive care. So there's a, I would say, strong imperative among the part of many of the critical care clinicians to do something, right? So the idea that, well, we have to do something beyond supportive care. And it's really interesting to see what people are doing. There's a wide range in this community. And I would say, we're a relatively tight-knit group of intensivists, many people trained at the University of Washington. We know each other. And yet the range of treatments is impressive across hospitals and institutions. And it's certainly not evidence-based because there is no evidence for any of it. Some of it is mechanistically plausible, right? So people are making mechanistic arguments for why this drug or this intervention might be beneficial. But there are also mechanistic reasons to think that it might be harmful. Steroids would be the best example of that, right? So there's the argument that, these patients have overactive, pro-inflammatory response to infection, and so we should give them steroids. But it's also very clear that steroids are immunosuppressive. These patients often cannot clear their virus. What we're seeing is the patients who are on the ventilator are persistently positive.
So I was going to ask you that. Do you routinely follow viral loads, or
we don't? We're not doing it. We're not doing it as a matter of routine, but we do it on occasion. Where we do it as a routine is before a patient is discharged. So we're not doing it on everybody on the ventilator, but before a patient is discharged, they need negative swabs. So on the acute care service, they are doing it prior to discharge. But what we're seeing is, these patients are persistently shedding virus. So why give them steroids, right? And so within the community in Seattle, there are places that are giving steroids to all patients after some period of time on the ventilator, and other institutions that are not giving steroids at all. Early steroids, I think we all agree, are probably harmful. But then in terms of antivirals, there's a wide range there. This is one of those areas where I am a firm believer in a randomized controlled trial. And so we are part of a randomized controlled trial of remdesivir here, as are most of the other institutions in Seattle. And I think that's going to be really important to try to see whether or not that intervention does anything for this illness. But then there are a lot of things that are being given just because somebody thinks they might work. Hydroxychloroquine is popular with the president, and there's some theoretical reason to use it. So people are giving that. People are talking about or using tocilizumab, which to sort of shut down the inflammatory reaction in these patients. That I think is, again, potentially fraught, right? If you're turning that off when the patient needs it. Yeah.
Is there any sufficient familiarity by now with the course of this illness once they get, on the ventilator, that with that familiarity, you might get a sense that something is promising or something is not?
I don't think so.
Okay.
I think it's too early. And these folks, they don't budge, a lot of them, I should say. I talk, it's not completely uniform, but a lot of these cases, you round on them day after day and things are exactly the same. And, you can try to intervene. And you're not going to see any dramatic effects. I really think the idea that we're going to see a dramatic effect, especially in a critical care population, is we're not going to see that. We all know that if antivirals work, they generally work when you give them early, and they shorten symptom, the duration of symptoms or the duration of shedding. They rarely work if you give them to somebody who's already, in the ICU. So I think the idea that that's where we're going to see a benefit. We certainly don't see it at the bedside. So yeah, it's the Wild West in terms of treatment.
Sure. The now infamous French study that was first presented before it was published, and its main claim was that the viral loads, in a way, indirectly measured by PCR cycle, thresholds, were coming down quickly. Did you have an immediate desire to test, to sort of confirm that and see if.
So we're not in a position to necessarily do that because our PCRs right now are qualitative, not quantitative.
Okay.
So we would have to ask our lab folks to do that. And again, I think that's one of those surrogate endpoints that doesn't necessarily make I get why people, it sounds like a good thing, but what we're really going to be looking for here, right, is survival, and are people going to get out of the ICU? And so I think a lot of these surrogate endpoints we know when we look at ICU populations are not particularly helpful. They're not predictive of survival. So it's going to be a while before we can sort out which of these things work and I hope, and it's a hard thing to do in the midst of a crisis, right? To gear up a good study or to get people to agree on a basic standard of care is really hard to do when you're in the midst of a crisis. Sure.
Are you intubating people sooner because of concern about, spreading the germs in the air if they had to use BiPAP or?
So we tend to, and I'd say most of my colleagues in the Seattle area are not using non-invasive positive pressure ventilation, except in certain circumstances. There's debate about, somebody who comes in with a COPD exacerbation that's related to COVID, but otherwise doesn't look like they have ARDS or, infiltrates. Mm-hmm. Non-invasive for patients who do not intubate. But we do know that aerosolizes, it's an aerosolizing procedure. And so, that requires a higher level of PPE if you're going to do it. And it makes really no sense if you're going to do it for somebody who is a candidate for mechanical ventilation, because we know this doesn't get better fast, right? Mm-hmm. Non-invasive positive pressure ventilation works well if you're going to turn something around in the next 24 to 48 hours. If they look like they have impending ARDS due to this, then we tend to intubate earlier rather than later and not use non-invasive. High flow nasal cannula is another debated topic. In really high flows, it's probably aerosolizing, and mm-hmm. lower high flows, it's probably not. And it may be a good therapy for people who are hypoxic but otherwise are not failing in front of you. But again, our colleagues at Evergreen have been very helpful in sharing with us, a lot of these patients, when they go down very quickly, and you don't have a lot of time. So you need to be prepared to intubate them relatively early in the course. I think that some people argue that once you get to 6 liters, you should intubate these people. I think that's ridiculous. Frankly, we've seen many patients who've gotten by on just, relatively low level oxygen support, 6, 8 liters, some oxymizers, or a non-rebreather, and not had to be intubated. And if you're going to intubate them, again, you better be prepared to do it for a while.
Have you seen mostly, we hear about some young people, everybody is potentially susceptible, including young, healthy people. But is it pretty much the case that it's primarily older folks with comorbidities, hypertension, heart disease, lung disease?
So we've, and I'll say, when I say we, I'm talking about the regional community. Again, the communication that mm-hmm. We're all doing with one another. We know what's going on at other institutions. And so we as a community have seen, yes, most of the patients who get severely ill are older and have comorbidities. And most of the patients who have died have had both. But we do also see this in younger patients. There have been multiple patients in their 20s who've ended up on mechanical ventilation, including those who really had no comorbidities at all. And we've seen, people who are not old like us, right, who are in their, 50s and early 60s, who've also ended up on the ventilator and have not had any comorbidities. It does appear early on that those are the people who are most likely to come off the ventilator. So not surprisingly, early on, it looks like things that have predicted a bad outcome in other places are clear here as well.
Okay. Let me ask you to put your medical ethicist hat on. Mm-hmm. I'm sure you've read the reports, the concerns about getting to a point where you're hitting capacity, and you have maybe a lot of older folks with shorter life expectancy and or who are maybe even likely not to come off the vent. What are the conversations or the things that go through your mind, through the mind of your colleagues when you're confronting this possibility? Is there any way to potentially prepare for that situation?
Absolutely, and we've been preparing for that situation here for quite a while. And within my medical ethics hat and critical care hat, I've been involved with the Northwest Healthcare Response Network, which is a group that's aligned with both the state and local health authorities, and have been in pandemic planning for a very long time. And there are mechanisms and guidance in place for these kinds of questions. I think one of the things that's most important to realize, that we don't reach what are called crisis standards of care. That is a standard of care where suddenly you're having to allocate a scarce resource at the bedside. We don't reach that as an institution. We need to reach that as a community. So right now, we are not at that place. We are doing absolutely everything we can to avoid being in that place. And that means, our surging, increasing our capacity for the surge, but also cooperating with all the other institutions in the region so that no institution gets overwhelmed while another institution has those resources. The state has been very engaged, and the governor's office has been very engaged in this process with us. And so we are making sure that if we reach that point where we are in crisis standards of care, we do that as a community, not as an individual institution.
Right.
That's
but how does that? What does that look like? If we're to project, yeah.
So if we got to that point, which again, all efforts are to try to make sure that we don't get to that point. If we got to that point, then the expectation that the state Department of Health and or governor's office, along with local health authorities, would say that we're at that state, right? That we now are out of, say, ICU capacity. We simply don't have ICU capacity, whether that be ventilators or staff. I think it's more likely to be staff and space than it is to be the ventilator itself, but say we can no longer provide that for everybody who might otherwise meet that requirement. If they tell us we're there, there are mechanisms in place to set up, and we're already setting these up here in case they're needed, triage teams at each institution. And the triage team's role is to look at who might potentially benefit from that scarce resource, and make sure that the resource goes to the person who is most likely to benefit. And that's a big change in the medical ethics world, right? Because as clinicians, we're used to advocating for our patients. Our duty is to the patient in front of us. And in this situation, it's a big change in terms of the ethical imperative, because now we are trying to provide the greatest good for the greatest number. Mm-hmm. And that's not something in healthcare that we're used to doing as clinicians. And so we take that responsibility from it's not the clinician's responsibility to do that. It's the triage team's responsibility to do that.
But still, wouldn't it be, I mean, if somebody shows up in the, or gets to the point where they need a ventilator, I mean, presumably they're already in the hospital and so forth, and there's one available. So I mean, if you have a choice, it's because there's a ventilator available, and then you choose not to give it to that person in anticipation of another person later on having the need for that last piece of equipment.
Or there may be somebody who's already utilizing a ventilator who no longer appears they're going to be benefiting from it. Right?
Okay.
And I think one of the things that's important about crisis standards of care, understanding crisis standards of care, is it applies to everybody in the institution, in the region. It's not just people with COVID. It may be other people, and maybe somebody with a stroke who's on the ventilator, and maybe somebody who has a massive heart attack who may need the ventilator, or somebody with trauma. That scarce resource needs to be allocated in a way that's going to the individual who's most likely to benefit from it. And if it becomes clear even after it's been allocated, then now that so say a COVID patient who's now developing multi-organ failure, and we know that patient's not going to survive, then we're not going to leave them on the ventilator if that ventilator can go to somebody who has a much more higher likelihood of benefit. Now, maybe that may not be another COVID patient. It may be a young patient with a trauma.
Sure.
Um,
Um, and I suspect there'd be, I mean, it's obviously a horrendously difficult situation, but any thought about, I mean, would it be that you would establish certain objective rules, or you would still have the clinicians, somehow involved on a case-by-case basis, or because...
So I think the key is what are the principles that ethical principles that you're really trying to maintain. And I think here what we want to do is make sure that the distribution, of a scarce resource is going to be done in a fair, equitable, transparent, accountable way, right?
Mm-hmm.
So the actual mechanism of that is you don't want the clinicians to do it because, one, they're not used to doing it, and two, it will become very arbitrary, right? Then you have clinicians advocating for their patient regardless of whether or not that patient's most likely to benefit. And so the triage team's role is to actually get from the clinician just the minimal amount of information that they need to get in order to assess whether or not how likely this patient is to benefit from the resource. So let's say ICU level care, and no more, right? Because the other thing is that you don't want these decisions to be biased. And you don't want them to be biased in any way, shape, or form on socioeconomic status, on race, on underlying disability that's not relevant to the medical prognosis.
Right.
You don't want these to be biased. So what you want what the triage team needs from the clinician. So for instance, in a COVID case, we need to know age because that's a predictor of outcome, not because
right.
Any other reason.
Right.
Comorbidities, not because we don't, that diabetes is not something that, we don't, that patients with diabetes aren't valued. It's because it predicts a bad outcome. So you would get the information around age and comorbidities and disease severity. And that would be all the information that you need to know to make, to make a prognostic assessment. We don't know a ton about this disease, but we know enough about this disease that you can make reasonable prognostic guesses, at least relative prognostic guesses, in such situation.
Mm-hmm.
And if it's a non-COVID patient, you need to get that information from the clinician too. What's the likelihood that if this patient, goes to the ICU, that they're going to survive the ICU?
Right, because you could have somebody with a severe trauma or whatnot.
Yep.
Yep.
And so you need to, so you may need the content experts to help the triage team and say, yes, this is the prognosis. But again, somebody with a severe neurologic injury under these circumstances where they might otherwise be supported, their prognosis may be horrible, traumatic, severe traumatic brain injury. Their prognosis may be so poor that resource would not be allocated to them.
Tough.
Yeah,
I hope you don't get to that point. Yeah.
which is why we don't want to get there. But I do think that
right.
Having a plan in place and having understanding these principles, and I think a lot of what I've been doing the last week is educating, hopefully some of the community, but also just my clinical colleagues about these things, because they're not something we're used to thinking about, and yet many of us have been thinking about them since the SARS epidemic. And there's a great deal of agreement in the medical ethics and disaster management communities around these principles and around these mechanisms. And there may be subtle differences between operationalizing them, but there's a strong consensus among these things. And I think what the public needs to hear is that this isn't about, this isn't a free for all. It's not going to be arbitrary. This is just, being in crisis standards of care doesn't mean there are no standards of care. It means that we're still trying to do the very best with what we have, and that we're gonna try to make sure that that resource is distributed, and again, in a fair and equitable and accountable way.
I understand. This has been extremely instructive, Mark. Any final thoughts that you want to share with colleagues, around the country, as other communities are, will be facing?
So I think
their own surges.
Yep. So the lessons that I've learned, and I think that we've learned is, one, it's never too early to try to flatten the curve. All right. So if you wait until you really feel like you have to, and this is a message you need to get to the those in power. It's really never too early. So get on that. It's never too early to implement your contingency plan. So don't wait until you're overwhelmed before you start knocking out walls and putting in negative pressure rooms and expanding your critical care footprint and shutting down elective surgeries. Again, if you wait until you're overwhelmed, then it's too late. And then the other thing that's been really crucial, and I credit one of the local pulmonologists, Ann Lipke at Swedish, was the one who started this very early on. Just we know each other, and most of us have each other's phone numbers. And the communication between the critical care community in this region has been tremendous, and it's helped in ways you didn't even imagine. One, in terms of trying to help distribute these patients. We're all trying to help each other out, and if one spot gets overwhelmed, we see a small community hospital gets overwhelmed, we're all helping. We're all helping out in a way that our transfer centers can't even facilitate, because there's no central mechanism to date to do that. And then also just all the stuff we talked about, like how are we making decisions for these patients? What are we doing and why are we doing it? I don't think that we're going to reach a consensus in care here in the next few weeks, but it's really interesting to hear why people are doing things and what they're seeing. Like you said, some of this stuff we don't we're not going to be able to tell whether a particular intervention is effective, but maybe, but we know we can find out what's not working. We can find out what to expect. And again, like I said, the folks at Evergreen, who were the tip of the spear on this one, have prepared the rest of us for what to expect. And it's really been great. So good communication, I think, is the key.
Mark, thank you for what you do. Yeah, I mean, and we didn't mention, but it's obvious that you also put yourself at risk, being on the front lines, to some extent. I'm sure you take precautions, but nevertheless, that's also,
and it's
been part of the job.
And it's been great to see all my colleagues. I mean, the nurses and the respiratory therapists are the ones spending the most time in those rooms. And they've been just tremendous. And we need to really do whatever we can to support them and make sure that they're safe. But yeah, and watching your colleagues step up and volunteer, there's some positive in this.
It's good to hear, and certainly you're setting a very hopeful example. So thank you very much.
We'll all get through. Yeah.
Okay.
Okay.
Bye-bye.
All right. Goodbye.